Welcome back for another lecture, and this is Dr. Terkawi. Today we're going to talk about peripheral nerve stimulators. I don't have any conflict of interest to declare, and as usual, this is an education material for healthcare providers. So if you are a patient watching this patient, you are welcome, but please consult your doctor. So in this lecture, I'm hoping to go over some potential mechanism of peripheral nerve stimulators, what's the available evidence, common stimulators available, potentially good indications, how to do it, and complication. So it's a nice overview. So peripheral nerve stimulators, or peripheral nerve stimulation, I should say, is not really a new technology. However, what make it flourish in the last few years, the advance in the stimulators. Nowadays, we have better leads, we have better stimulation modalities, and this is why we are able to do more challenging cases and using percutaneous placement of these leads closer to the nerves, which and have an external generator that the patient control, and that's how the patient usually get pain relief. So the potential advantages of peripheral nerve stimulators, it mostly does not really induce any sensory, motor, or proprioception deficits. It's not like the nerve block, it's not like the cryotherapy, it's not like the radiofrequency ablation. It should give a sustainable relief, sustainable benefit, because it's there. The patient can turn it on as long as needed. It is less invasive than spinal cord stimulators and easier to remove. The patient can control the amount of stimulation, so think about it as more like a personalized treatment. And it may help regenerate injured nerves. So there is also a therapeutic effect here. It's not only treating pain. Potential mechanism of actions. This is still a growing area, and there's a lot of ongoing research here. But the two main theories, one is working on the pain gate pathway, basically distracting the pain pathway, so the end result, less pain transmitted through the nerves and less pain perceived by the patient. The other potential mechanism, which is regenerating the axons of the injured nerve. So this is a recent review that looked at the changes at the micro level. So basically, electrical stimulation proximal to injured nerve will stimulate the upregulation of the regeneration associated gene, the RAG, through a calcium-independent mechanism. Increased expression of BDNF and other mediators will eventually increase expression of cyclic AMP, which activate CREB to maximize the pro-regenerative axon phenotype. Electrical stimulation causes calcium and sodium to flood the neuron. So basically, it creates more action potential. It's exactly the opposite of nerve block. When we do the nerve block, you stop the action potential. Here, you create more action potential. In vitro studies showed, and that's even from the early 2000s, that a single session, 1 hour stimulation of an injured nerve at 20 hertz, increase the calcium influx to the nerve and cause subsequent changes with eventually promote nerve regeneration. So what are the available evidence nowadays? There are a handful of new systematic review that published in the last couple of years. So this is one of them where they included 16 randomized clinical trials, the rest of them in data based on case series and case reports. Overall, because of lack of high quality randomized, there is a lack of high quality randomized clinical trial, and therefore they were not able to pool data, so they didn't do meta-analysis. However, when they conclude that there is level 1 and 2 evidence for the use of peripheral nerve stimulator for chronic migraine headache, level 2 for cluster headache, post amputation pain, chronic pelvic pain, chronic low back pain, and lower evidence for other indications. I think what's really important here that they found this therapeutic modality safe and reversible. So there is no serious adverse event reported on all these cases. Now here is another study that was published a few months ago. So this time they included 20 randomized clinical trials with a bunch of prospective observational studies. Again, the same, they were not able to do meta-analysis. They were not able to pool data because, again, we still need more studies. We need more clinical trials. We need better studies. So this is a growing field. So this is the right time, if you are interested to do research, this is the right time to do research. And I want you to just show you a couple of things here. So based on their definition, level 1 is anything that has at least one controlled randomized trial. So if you see that level 1, that doesn't mean you have many randomized clinical trials. One is enough. Degree of recommendation: A, extremely recommended; B, recommended, and you go down. So this is their conclusion. So basically, as you see, there is no grade A, so no extremely recommended. There is a bunch of grade B, which is recommended, right? Level of evidence, you have also a handful of 1, which means you have some randomized clinical trials. As I said, most of the trials came from a headache, so migraine, occipital pain, etc. And some studies here for shoulder pain, and there is also a handful in post-amputation and lower extremity neuropathic pain. So overall, I would say that available data are promising, but still we need more research in this area. Here is another randomized clinical trial that was published a couple of years ago. Very well conducted study. So basically, but this is for post-surgical pain, not really for chronic pain. So they implanted or placed peripheral nerve stimulators at different nerves, sciatic, femoral, brachial plexus, for different surgeries. And they randomize the patient and follow up them for 14 days. In each group, the stimulation and the sham, we have 30 plus patients. And what they found that in the first 7 days, for the opioid consumption, which is really important here, there is a big difference between those who had the stimulation versus those with a sham group. And this difference, as you see, it's both statistically and clinically meaningful. Echoing that, they also found the average pain was about 1 in the stimulation group and about 3 in the sham group. So as you see, despite its small study, but there is good outcome here with big clinical effect size. So, what are the common peripheral nerve stimulators that we have out there? So, in the US market, uh, as the time I'm preparing this lecture, there are five FDA approved peripheral nerve stimulator companies. You have here Sprint, you have Bioness or Stimrouter, you have Nalu, you have Stimwave that recently changed to Curonix. And there is, of course, some difference between them. If you look here in the diameter, the smallest one, the Sprint, then, and the rest of them, they are very close to each other. The length is varies a lot. So Sprint up to 12 centimeter. This is 15. This can be longer. Nano longer, and you can add an extension to that. The electrodes also, this is a tip stimulation here. This has 3 electrodes, 4 electrodes, and with the trial you get 8 electrodes. Here again, 4 electrodes. The frequency, as you see, it really varies. So Sprint has a up to 100 hertz, definitely higher with Stimrouter and Simwave and Nano. Intensity, amplitude, a difference. Pulse width is difference. Also, the mode of stimulation, there is difference there. Now, generally speaking, Sprint marketed as a temporal stimulation up to 60 days, and the rest can be permanent. Now, when we say permanent, that doesn't mean forever. That means you can put it there and you can explant it when you don't need it. In terms of MRI compatibility, Sprint is not MRI compatible, and the remaining they are MRI conditional. So it depends where is the MRI doing, and you have to really adjust few things in the MRI. And there are differences in the size of the battery and the IPG and where you're gonna place it. This is the mainstay or the reactive 8. This is only indicated and used for mechanical chronic low back pain with no prior surgeries, inadequate relief with conventional treatment, non-radicular neuropathic pain, and basically you target the L5 middle branch block. And there is some evidence that this can regenerate the multifidus muscle and etc. So what are the potentially good indicators? Now, and this is why I said we need more data. We don't have really a guidelines saying, well, this is the nerve, the best nerve you stimulate or whatever. But here I try to summarize from our clinical experience. So peripheral mononeuropathy or neuralgia, you name it, common peroneal, sural nerve, ulnar nerve, median nerve, you name it. CRPS type 2, the reason why I said type 2, because usually you know where is the injured nerve, how the injury started. But again, that doesn't mean you cannot do it for type 1, as long as you can find a target. Post-limb amputation pain, like below-knee amputation. Chronic post-surgical pain, that's more like a growing field, especially if you catch it early on. And mechanical low back pain, still a growing field as well. Now, this is a paper that we just published last month. And this is really a clinical approach to chronic pain due to perioperative nerve pain. I highly recommend you read this. It has a lot of useful information, but I have few slides from here. So, for example, this illustration show you the potential nerve injury that you can get with different kind of surgeries. And as you imagine, each one of them can be potentially an indication for peripheral nerve stimulator. So, for example, let's take the total knee replacement as one of the common surgeries. So multiple nerves can be injured: common peroneal, lateral sural nerve, saphenous, infrapatellar, nerve to vastus, medialis or lateralis, and genicular nerve, and you name it. You can pause this and look at all these multiple surgeries. Here is another slide with different surgeries, like, for example, above knee amputation, sciatic nerve, femoral, saphenous, etc. And now here is a diagram that um, really show you the algorithm that we follow in a smart way, and I'm going to explain it in a second here. There is, again, this is mainly based on clinical experience and our search of literature, but I cannot say this is based on clinical trial. So there is two ways to look at this diagram here. The first one is basically, this is how the algorithm goes. So you usually start with peripheral nerve block with steroid. That can be both diagnostic or therapeutic. If it doesn't do the trick, you can do radiofrequency neuromodulation, cryotherapy. If that doesn't work, you can try peripheral nerve stimulator. If that doesn't work, you can try dorsal root ganglion or spinal cord stimulator. So this is one way to look at this screen. The other way is how to choose among these modalities. And it really boils down to two factors: the duration of the pain and the severity of the pain. So here in the y-axis, you have the duration of pain. Obviously, the longer the duration, the more challenging to treat this nerve. The more severe in the y-axis, in the x-axis, the more severe the pain, the more challenging. And the severity can be mild, moderate, severe, or even can be CRPS type 2. So let me give you an example. Now, let's say you had a patient who has, let's say, superficial peroneal neuralgia after X surgery, and this patient pain is moderate. And this has been only, let's say, 5 months. This patient get lucky, see a pain physician after 5 months. So if you draw a line, so you will see that you situated in the area that the radiofrequency neuromodulation and cryotherapy potentially can be the definitive treatment, potentially. Again, we always start with a steroid injection because you never know. I have seen multiple patients. I was surprised that just with single injection of steroid it cure the pain, especially if the pain not that severe and it's like, let's say, less than 6 months or less than 3 months, etc. Now, another thing I want to point out here that when I say permanent peripheral nerve stimulator and temporal, by no means I mean a specific company. So temporal here, I'm not pointing to a specific company. What we mean that you might need the peripheral nerve stimulator for certain time, short time, maybe few months, few years. So that's what we refer here to temporal and permanent. Now, how we select a good candidate for peripheral nerve stimulator? So as any other procedure, patient selection is really the key for success. So let me give you a few tips. So first, diagnostic block. So the diagnostic nerve block. So when you do the diagnostic nerve block, please use the least possible volume. If you use high volume, then when you have a dense block, that can give you a false positive result. This is one trick. The other thing, you should always educate the patient that the peripheral nerve stimulator will not give you the exact same amount of pain relief you have with the block, because the block, I completely shut down the nerve here. Stimulation, I cannot shut down the nerve because I still want the nerve to be function for you. So I don't want you to expect the peripheral nerve stimulation will give you 100% the exact same pain relief. Now, you might get lucky, but I cannot promise. Then another, way to look at this, having a successful trial. Now, some companies, like for example, StimWave and Nalo, you can do a trial for 7 days or whatever, and then if the patient like it, then this is really a good predictor of how the patient will respond to the implant. So always set up expectation. Expectation very important, and educate the patient. It's very important. I found this very important. So for example, there are stimulators, how long it will last. It really depends on how strong is the stimulation, how big is the nerve, multiple factors. So the patient need to know and have some expectation. Then psychological evaluation and optimization. So psychological evaluation is not really a mandatory requirement, but I highly recommend it. You don't need to always refer your patient to psychologist. You can use your judgment. Now, if your patient is anxious, pain catastrophizing, you have to optimize that before going to this implant. Because what happened that this is this will be a weird experience for some patient. So once you start to stimulate their nerve, they just can freak out, and that can flare up the pain. So this is very important to keep in mind. Another thing, the nerve location and size. Now, again, this is from clinical experience. So let me give you an example for nerve location. This is a very good example. So for example, let's say the sciatic nerve, whether you're going to do it all the way up, gluteal approach, mid-thigh, or even popliteal. One of the challenges with the sciatic nerve, especially if you are placing the stimulator very close to the nerve, your patient prone, you put the lead posterior to the nerve, is positioning. The minute the patient sit, the minute the lead will like squeeze against the nerve. And then the patient will jump from the stimulation. Oh, it's a high stimulation. Then we'll crack this down. The minute they stand, this will become a weak stimulation. And then they have to crank it up. So this is really a challenging to do sciatic nerve stimulation. So you have to be very thoughtful where you're going to put the lead, how close to the nerve. And this is also important. And the size of the nerve. So, for example, some people try brachial plexus. Well, the brachial plexus is really big. There is no way you can cover the brachial plexus with one lead. Another things to keep in mind when thinking about good candidates is to evaluate the risk of infection and complications. So, and complication here, I'm going to go over that, but really the lead migration. So there are some anatomical considerations. So, for example, morbidly obese patient, there is a higher risk of infection. Amputation with prosthesis. So I'll give you example here. Let's say you have an above knee amputation and you did a diagnostic block for the sciatic nerve. Boom, you have an outstanding result, and you decided to put a stimulator. Now, you place the stimulator where you're going to put the IPG or the battery. You have to either extend the lead or use a longer lead so you can tunnel it above, let's say, the pelvis. So when the patient wear the prosthesis doesn't, you know, interfere with the stimulation, or you cannot just put the prosthesis above the stimulator. So let's say you do this, and then the patient start to wear the prosthesis without complete healing of the wound. That's another risk of infection. Close to poor hygiene area, You name it, there are many examples. Immunocompromised, like poorly controlled diabetes, and others. Now, how to do it? Now, this lecture is really not intended to give you all details about the procedure, but I will go over some examples here just to give you an idea. Now, there are, as I said, multiple companies. Each company has different kit. Each kit has slightly different, tricks, but overall, it's a very similar concept. So here is one of the companies here. If you notice, it has to be completely sterile, and I do give a dose of IV antibiotic as prophylaxis. Sometimes, if I feel there is a risk of infection, I might send the patient with some oral antibiotic as well. Now, the first step is really to pre-scan. So you get your ultrasound, start to scan, find the nerve, look for the course of the nerve, and really plan your procedure. So as you see here, I put a lot of marks where the target will be, where I'm going to start, what's my trajectory, how I'm going to tunnel the lead, and where we'll use put the stimulator outside. And then you need an echogenic needle. You can use, let's say, 22 gauge spinal needle. You can use 2He needle. Some companies, they have that in the kit. Some of them, you need to get it from outside. Not a big deal. But once you place the needle, you get close to the nerve, then you place the probe, um, and then and then you stimulate. Once you are happy, you take your needle out and you put a trocar, and that will dilate the space. So the next step will be you put the lead inside. So this is the lead here, and then again stimulate just to make sure you are happy with the stimulation. Now, speaking of stimulation, I sometimes I don't really go with stimulation. So I'll give you an example. Let's say I'm doing a big nerve, whatever you name it, saphenous, femoral, and I'm really happy with the anatomy. I'm seeing the nerve, like this is the lead, like I'm very satisfying. So I don't really depend on the stimulation. That doesn't mean I don't stimulate, because what happened with big nerves, you have a lot of fibers inside. So it's very important to decide where you're going to put the lead. Is it above, below, lateral, medial? Because sometimes you will be surprised. You are touching the nerve, you are stimulating the nerve, but the patient feeling the stimulation in not in the nerve distribution, but not necessarily the pain distribution. So you want to make sure eventually to stimulate and you are happy with the distribution, like the stimulation going toward where I usually feel the pain. That's how I like to do it. And then after that, you know, you confirm that, and then you deploy the lead. So for example, here is my target. I push the lead from this way to this way. And then here again, companies are different. You peel off that piece, then you feed the lead here and you tunnel it. So for example, I tunnel it this way because eventually you need the stimulator to be above the lead. Again, multiple companies, there is some variabilities there. So this is an example of posterior tibial. Here is another example of superficial peroneal. I did the sandwich technique where I put lead above and below. So that was my target here. I started from here to here and then tunnel the lead here and here. And notice in this example, you should, there is a certain distance, like 7 centimeter, for example, for this company, you should not exceed it. And now, as you see, I only have one entry point. I don't suture it. I just dermabone it, and I have really a good result and outcome with that in terms of infection. Here is another a company. This is medial branch nerve stimulator. Very similar technique, slight differences here. We'll not go over details here. Now, can you have complication? Yes, you can have complication, but fortunately, they are really rare. They are, in general, rare, except lead migration. It can be really common. Again, we don't have solid data, so I can tell you this is the percentage, but this is the most common. And as I said in my previous lectures, we have to be thoughtful about the nerve, the position. So, for example, if your lead in the buttock, let's say you're doing a pudendal nerve, these are strong muscles, the patient always moving them, so you have a higher chance of lead migration than, for example, sural nerve, where it just laid over like a long bone. There is no much major movement on these muscles, so the chance of lead migration with the sural stimulation is less than the pudendal nerve stimulator. Lead infection, fracture, failed to or lack of efficiency, and skin irritation. That's true with some companies due to adhesive material. Here is an example of infected lead that eventually get extracted. And here is another example of fractured lead. And obviously, you cannot really diagnose this except with X-ray. But as a rule of thumb, let's say you have a PNS that was working beautifully, and now all of a sudden the patient lose benefit. The first thing I would do, bring the patient, scan with ultrasound, make sure the lead's still in position to rule out lead migration. Number two, I'll do an X-ray to rule out lead fracture, which again is rare. And of course, before that, we should troubleshoot and make sure the stimulator is working. I hope you found this enjoyable. This is just a brief overview, and thank you for your attention.